It's a pleasure to be here today. What I'm going to try and do in my allotted time is to focus on the kinds of concerns that your deputy minister has already described and that you're, I'm sure, very well aware of, which is this is a period of considerable ferment in healthcare systems generally, and in tax-funded systems, publicly operated systems in particular. I'll say a few things about it just to set the stage. But then what I would like to do is to give you some case examples. They were chosen from countries that had some similarities to Alberta, typically population sizes that are similar, countries of around 5 million, but also countries that are trying to grapple with some of the questions that are part of the scene in Alberta. What the context is, you know well, which is that at the economic level, and it's not, by the way, as I'm sure you're aware, it's not just an issue of oil tar sands in Alberta. European economies have essentially stopped growing, with one or two exceptions, neither of which are sustainable over time. You have a whole series of economic measures in place, a series of economic crutches, like negative interest rates, that suggest that the situation really is rather dire and not sustainable. The upshot is that there's little political capital for reforms, and there's obviously not much financial capital for reforms. That leaves ministers in all these countries trying to wrestle with the issues I have listed here under the health sector level of this slide, all of which are well known to you, all of the dilemmas in systems. There's a further dilemma, which is what will happen should interest rates normalize and how that will play its way out. But that's unlikely to make things better, and it may make things worse. In other words, from here, it's not a quick escape. I guess that's the takeaway. And in practical terms, what that means, at least in Northern Europe, and I cannot speak for Alberta, obviously, because of the character and structure of the Alberta economy, but in terms of countries in the Nordic region, but also on the continent, there essentially is going to be no new near-term public revenues. They're going to be forced to try to rethink the way in which they structure and deliver care with a finance side that is essentially frozen. That's no new public revenues. The question is whether one is willing to pursue some non-public revenues. And that gets into many different complex questions, again, things that I'm sure you're well aware of. Different countries have been trying different strategies to, in a sense, get various types of private money further involved in funding healthcare. And sometimes it works, sometimes it doesn't work. It's always contentious. In thinking about what some of the initiatives have been to respond to this situation, when ministers and ministries look at the picture I just laid out, the two places that they first turn to, one are structural efficiency initiatives, and the other, of course, are financial changes in the way that the existing money flows. And this slide contains a number of the different initiatives that European countries have pursued. A number of these initiatives I will go into in more depth when I get to the case examples. I'm going to talk about, I think, 5 countries very specifically in terms of some of the changes they've made and how that fits into the picture. But just to quickly take you through these, because this is in a way a laundry list of options from a structural point of view. And again, primarily from tax-funded systems that are publicly operated, publicly funded. One is the whole question of consolidating hospitals, particularly district hospitals into regional hospitals, finding ways to have more central administration, finding ways to move certain specialist services from multiple sites to single sites. Second is centralizing various kinds of administrative and budget controls. You will hear a whole discussion through this presentation of two things simultaneously that are contradictory. There is a lot of re-centralization going on in European systems, at the same time that there is a lot of decentralization going on. The re-centralization is taking place on specific targeted areas and is designed to be compatible with the decentralization that's taking place in other areas. But it's basically a reallocation. It's a new pattern of governance that's beginning to emerge. We have to see whether or not these initiatives can be implemented, whether these initiatives succeed. But the process is one of rethinking how public authority is used in order to produce the results that's desired from systems. So there's consolidating hospitals, re-centralizing administrative budgets, decentralizing other parts of administrative budgets, particularly for what the Europeans call social care. Long-term care and home care are the two primary components in that use of the term social care. Combining health and long-term care in the same administrative agency. A number of countries are pursuing that, and that's something new in those countries. I'm aware that in Alberta that has been part of the picture for some time. Shifting this whole question about how you deal with the chronically ill, but essentially shifting them out of structured care, residential care, and moving them to less expensive forms, primarily around home care. Two strategies for doing that are the last two on the bottom, both from Norway and Denmark. One is to create, at the municipal level, acute bed units, what they call MAUs, municipal acute units, essentially step-down beds, as well as observation beds. Some way so that if somebody who is chronically ill and is no longer stable at home can be taken into an intermediate local facility without having to utilize the emergency room and utilize expensive inpatient care. Another strategy, the last one, is the embedding of primary care units inside hospitals. This, again, is particularly a Norwegian concept, although I guess in Denmark they are starting to do this as well, with the idea that these serve as discharge facilitators to ensure that continuity occurs between the inpatient hospital facility and the actual care providers, both at the primary care level and also in terms of services at home. So this is a whole litany of different alternatives. There are others, particularly from Norway, which I will add when we get to the case example. There's also waiting time guarantees, which have been put in place, quite different waiting guarantees, depending on the country, but in an effort to try and put pressure on the system to produce care more efficiently, and also expanding patient choice to private hospitals. Both Denmark and Norway, the public system will pay for use of private services, and it's the choice of the patient to do that. That in turn, again, puts pressure on the public system. Beyond the structural efficiencies, there's a whole range of managerial efficiencies. What do you do inside the supply and delivery chain? Most of these are fairly standard approaches. Call your attention to regionalization of clinical subspecialties, which was part of consolidation at the hospital. In a number of European countries, the national government is essentially forcing regional administrations to work with their neighbors and to have fewer units doing specialized care, but doing it in a way that allows them to have higher volume and therefore higher quality, better outcomes. There are also, that was what I was looking for on the previous slide, in terms of managerial efficiency initiatives, both Norway and Denmark have put in place mandatory agreements between the municipal governments and the regional governments that run healthcare, because the municipalities are responsible for the long-term care, the home care, and in Denmark, the nursing home care. These municipal agreements I'll say more about, but they are supervised by the national government, and they force municipalities to provide a broad range of services. One point about municipalities, and this came up in our discussions this morning, in the Nordic countries in particular, actually as part of the reforms in Denmark in 2006, they've consolidated municipalities into larger units. In Denmark in 2006, they took over 300 municipalities and reduced them to, I believe it's 95 or 97. And they did that so that the municipal unit would be large enough to be able to support, through taxes, an administration that could take responsibility on for something like these municipal agreements with the regional government. So they restructured their municipal governments in order to be able to better provide the kinds of services that are now expected in countries like Denmark and Norway from the municipal governments. Okay, moving with that as a kind of general overview of the lay of the land, the way in which the pattern is changing. I'd like to move to some of the cases. And here, hopefully, you will see some ideas, perhaps that are transferable or adaptable within what I recognize as a somewhat different context in Alberta. Norway has certain similarities, although as we were mentioning this morning, I guess they have a somewhat larger sovereign wealth fund than Alberta does. But geographically, it's somewhat similar. The dependence on oil, obviously, also is similar. Norway has engaged in they have engaged in two separate health reforms. They are currently writing the commission report to put in place what would be a third health reform within 14, 15 years. Still seeking to find the right balance between central and decentral, in essence. In 2002, what Norway did was to restructure the existing health system by eliminating, this will sound familiar to you, eliminating the regional level and taking all responsibility to the national government. They then recreated a regional level, but a regional level that was no longer elected by the citizens inside that region, a regional level that was appointed from Oslo, and whose job it was to administer hospitals that had been changed into a form of semi-autonomous, semi-independent operation, what they called state enterprises. What in England is called self-governing trusts. There are different names. This concept of taking public hospitals, giving them more autonomy inside the public sector to make decisions, to invest, to change their service patterns, is an idea that substantial number of countries now in Europe have put in place. And on the website for the European Observatory, there's more information about that. We actually have a book on governing public hospitals, if that's of interest. But that was part of the Norwegian reform in 2002. They pulled the budget and control back to Oslo. They set up deconcentrated regions. First 5, and then they merged it into 2 of them together and made it 4, but that were responsible to Oslo, not responsible to the citizens. And they turned the hospitals into entities that essentially had to demonstrate productivity on contract basis in order to get their budget. But then those hospitals had some control over how to use that budget as well. The funds all came in 2002 from the national government. That was a big shift. The regional government's no longer taxed, which had been the traditional Nordic model. In Denmark also, the regional government's no longer taxed. In Finland, the new proposed reforms I'll show you in a minute, the regional entities, they won't be governments, will no longer tax. So there's a pulling into the national government of fiscal control. So in that sense, perhaps Alberta was ahead of the process of reform. In terms of Norway, from 2002, they moved on 10 years later and put in place a whole structure of reform around long-term care, around home care and nursing home care, which revolved on decentralization to the municipal governments of a substantially larger amount of responsibility for running and also partly for funding long-term care. What I mentioned about these signed agreements, they're fairly comprehensive. You can see on the list here. It covers the interaction between the hospital sector, which is run by the regions, and the municipally run home care services, long-term care services. There are national guidelines and standards for what's supposed to happen, what's in the agreements. There are aspects about admission, about discharge, about rehabilitation. All of these are obligations the municipality is required to meet. In Denmark, and also in Norway, part of the cost is transferred from the national government to the municipality to do these things. In Norway, and they put in place something that originally began in Denmark in 20 years ago, and the Swedes put in place about 20 years ago, which is that municipal governments who are running the long-term care, both nursing home and home care, have to take back patients when the hospital designates them as ready for discharge. If the municipality is unable to take those patients back, if they don't have services to provide or space for those patients, in Sweden the rule is 5 working days after the patient has been announced. If the municipality can't take them back, the municipality has to start paying a fine to the hospital. You have a very interesting process going on here. You have 2 different public budgets in which you've created market incentives for performance between them. You have the municipality with its public money being told that unless it performs, it's going to have to pay a fine on a daily basis, and it's a substantial fine, to the hospital operating, they don't actually own them, hospital operating county governments. In Sweden, which is similar but a little bit different in the structure, it still has elected regional governments. In Sweden, when this was put in place in 1994, the expectation of the regional governments, the hospitals, was that they were going to make a lot of money. There was going to be a way they were going to tap some of the resources that the municipal governments had. But the interesting thing about market incentives, even when it's between 2 public budgets, is that the municipalities ended up taking back 85% of all of those patients in the first year. They paid very little to the regional governments because it was too painful to take municipal cash and to give it to a regional body, even if both of them, the regional body was a public body. So there's an interesting history, I guess I'd say, about that mechanism. And that's now, in 2012, that was introduced in Norway. I've already mentioned the municipal acute bed units, basically either step-down or evaluation beds, the embedded primary care units. As part of these agreements between the municipality and the regions, which have to be approved by the national government, municipalities have to have home-focused rehabilitation programs, and they also must implement a national pathways clinical care best practice program. All this is required of the municipal governments. This is, if you will, it's part of the deal for receiving support, financial support from the national government. The third element in the Norwegian reform, which is what is proposed and what I said was currently sitting and the report is being written. The Observatory has been involved in trying to provide some examples to the Norwegian government. They have 3 different strategies that have been proposed for essentially getting rid of the already weakened regions and having the national government just run all the hospitals out of Oslo. Again, that might sound like a familiar pattern in Alberta. One other thing about Norway that's interesting to keep in mind, which is I found a little bit shocking when I learned about it this summer. Nursing homes are public, but you are expected to pay a considerable amount, a considerable proportion of your pension, because the pension is from a national government fund. But the figure that I was told by the head of the Health Policy and Economics Department at the University of Oslo Med School is that you have to pay 80% of your income up to $100,000 per year for nursing home care. So there's a considerable amount of money that is changing hands around nursing home care depending on the income of the family. Nordic systems are traditionally egalitarian. They're traditionally concerned with not using co-payments as a way to discriminate against lower income people. And this does not, but middle and higher income people, or middle and higher people of means, people of middle and higher means, I guess, do have to pay considerable sums for nursing home care. So to pull this together, Norway, on a structural basis, what they're looking for is better coordination between hospitals and the long-term care. Municipalities are being required to put in place intermediate care delivery organizations, as well as to work with social care. On the financial side, the national government is now paying for it. One thing I forgot to mention from the 2012 reforms is that municipalities are given funds, but then they themselves have to pay for when their citizens at the hospitals receive services from internal medicine or from the outpatient clinics. That's another incentive that's being used to have the municipal government find ways to not have unnecessary admissions from chronically ill elderly. Most of this has not yet been evaluated in any substantial way. It will be very interesting to see how well it works. Finland. I'm not sure what I'm going to be able, how much of this I'm going to be able to do in terms of time. We're dealing with some of the least straightforward countries in Europe, Finland, and then I want to talk about Netherlands and long-term care. Finland is in a very difficult, complex process with a big coalition of putting in place new reforms. What the reforms are going to do is to combine, when we talked about centralization, they're going to combine hospital care, primary care, and long-term care in one administrative body. They are going to take primary care and long-term care away from municipal governments, exactly the opposite of what Norway is doing. They're going to pull it out from the municipal governments and put it in one administration, and then they're going to restructure these administrations into what they're calling health and social organizations. Social, again, meaning long-term care, which are called SOTE, S-O-T-E. Legislation was just sent to Parliament 2 weeks ago to implement this, and they expect to implement it. Actually, my dates in here are wrong. They expect to implement it in 2018. They're going to do it in 1 year. Most of the people in the ministry in Finland said that it wouldn't be possible to do it within 10 years, so that this is going to get very interesting. The purpose of these SOTE is to re-centralize all the services, but then to contract out or deliver through their own hospitals care, but with the idea that there'll be a contract relationship and there'll be some pressure on hospitals to compete with each other. That remains to be seen how well that will operate. There's several other initiatives that are underway. One is to take money out of occupational health, which is currently being used for primary care, and to put it into this new public arrangement. It's not clear how that's going to work out. The interesting innovation here is the first one, exactly the opposite of the Norwegians. The Norwegians are strengthening municipalities. The Finns are removing responsibility from municipalities. Two different examples, opposite directions that you could look at more closely. With England, there are a couple of examples that I think are salutary and useful. One is an effort to save money and to deal with dramatically visible public distress over the whole question of cancer drugs. The effort was to set in place a separate fund that would deal with drugs that were not acceptable on a quality-adjusted life-year basis by the National Institute of Clinical Excellence, by NICE, and to find another way, another channel to get some of those drugs into the public system, because patients were, putting it mildly, decidedly unhappy that they did not have access to more recent drugs. And the fund started in 2011. It had a fixed amount of money each year. It was supposed to be delivering those drugs to patients on an individual case patient basis as a way to get around the fact that it was violating the norms for what was considered to be efficient in terms of QALYs. Essentially, they ran out of money. They've closed and been restructured. It's still considered a contentious issue. One thing that is interesting, though, is when they reopened, several drug manufacturers dropped the price of their new cancer drugs. You probably know the new cancer drugs can be very expensive. But several manufacturers dropped their prices in order to make sure that they would get on the list to be included for the NHS. So there's a lot of negotiation and bargaining going on around that particular branch of pharmaceuticals. The second case from England is more directly relevant, potentially, to Alberta. And it's this pilot in Greater Manchester to decentralize control over the budget from the national to a regional level, at the same time that they centralize, combine, consolidate long-term care and nursing home care, what they call social care in England, with primary and hospital care. Again, like the Finns, putting all three in the same basket. There's a long history about why that doesn't work and why they were broken up 20, 30 years ago, different era. So there's a lot of question as to how this is going to work. In Greater Manchester, they are going to combine 30 different statutory authorities and have them join together in what's being called a health and social care partnership. And the idea is to create greater coordination and collaboration. The concern is that there is no statutory authority. They're simply being given the budget. Nobody's changing the legal characteristics of the system. And the fear is that this might turn out to just be another talking process. But they have a very large budget. They also have £400 million, £450 million of startup money. Although that looks, from what I can see, like it's going to be used by the local labor councils to put it into various kinds of client services rather than into the health and social process. So Oh, and there's one more thing they've done in England, which is interesting from a European perspective. I don't know from an Alberta perspective, which is that the national government has worked quite hard to create legislation to make it possible to set up not-for-profit providers, which most Northern European countries have lost. They had them prior to the onset of the full welfare state, but now they're trying to start to recreate not-for-profit private providers that would be locally controlled, community controlled. And in England, they have been successful in doing that. So in terms of the English picture with the Manchester experiment, you have both decentralization to Manchester from the National Health Service, but then re-centralization in terms of the structure of services. Ireland, there's a long history of moving boards around and reconstructing. They now have a single national health board but a purchaser-provider split with regional trusts that have to have their budgets approved. The interesting issue in Ireland is they thought they were going to move to social health insurance. They thought they were going to move from taxes to social health insurance. This is not a new endeavor. Mrs. Thatcher in 1989 wanted to move England, not just England, the United Kingdom at that point, because there was still only one NHS for all of the United Kingdom in 1989. She wanted to move the entire United Kingdom to a social health insurance plan. And she dropped that because it was clear to her as a fiscal conservative that it was more expensive. Ireland has now essentially repeated the process. Not that they would want to be associated necessarily, or that this government would want to be associated with Mrs. Thatcher's experience, which is they set out to put in place a social health insurance model. And it has now been determined that that's going to be more expensive than the existing and appears to have been dropped. So on the fiscal side, there's a lesson. The last case that I have for you is Netherlands, and it's particularly the whole question about social and long-term care and the reforms that are taking place. They are interesting because what they involve is not only more municipal responsibility in a decentralized way, but it's further decentralization to the individual and to the household and to the community. And it's very explicit in the Netherlands that that's what they're doing. That's part of the legislation. There's 3 acts that came into effect in 2015. Different parts of long-term care. For the part of long-term care that the municipality is responsible for, which is home care, for home care services now in the Netherlands, the first process that a potential patient goes through is to have a municipal social team come to your house, sit down with you, what they call kitchen table dialogue. It's very practical Dutch, the way it's defined. But the team sits down with you in your house and tries to convince you to do without municipal care. The purpose of the team is to say, what about your daughter? What about your husband? What about your neighbor? How can you make this work without us? The Dutch had a problem with long-term care getting more and more expensive, people becoming too dependent on it, and they, in typical Dutch fashion, just said, this stops. And that's what this legislation is. Once they put this in place, although people are legally entitled to residential care, to long-term care in a nursing home, but they've raised the standards for who they will allow to be admitted. And they've also cut the funding by 30%. One of the consequences of 2008 and the economic slowdown. And in turn, some of the municipalities who are now responsible for providing long-term care and who contract with private providers, they've cut what they pay to the private providers. And there are some private providers who say they're going bankrupt. So it's not been an easy process. But this is a slide that I have borrowed from Mirella Minkman, who is at the National Long-Term Care Research Center in the Netherlands, in Utrecht, that the whole structure of long-term care, the whole way of dealing with chronically ill elderly, this central question that is driving so much of this centralization and re-centralization in different systems. The Dutch approach to doing this is to move from central to decentral, from public spending to private payments, from professional care to self-care, from specialist to generalist care, from supply-driven to person-centered care, from quality of care to quality of life, and from institutional care to care in and by the community. And Wielands has this wonderful slide which conveys this shift dramatically. The center of the slide is the citizen, and it doesn't say the patient. In the Dutch, it's burger, it's citizen. And around in the green inner circle are the support tools for the individual. Spouses, children, local community. Is there a church there? The informal caregiving process, in other words, people who are not paid long-term care workers, unpaid workers. That's the core of the idea. And then the outer circle is some of the more formal structures, doctors, and you can see the hospital. It's the purple thing on the right. And the answer is you should never, ever get there until it's absolutely dire. That's the approach that the Netherlands has put in place, and they very explicitly say that it's related. I think it's on a, can I go back on this system? When I go down to the key premises, that it's very much intended to move clients from residential care to non-residential care, and from non-residential care to self-care of various kinds, with the understanding that patients progress through these stages as they age. To pull this together, the goals here are to shift decentralized long-term care out of the entire healthcare system, if that's possible. That's really the goal. One way, by the way, that when you are still in the system, or once you're in the system for home care, the Dutch have come up with to try and make it more efficient, this is a corollary idea, I guess, is what's called a personal budget. And this idea has now caught on in England. It's now being used in some parts of Sweden, and is probably one of those ideas that will percolate through other tax-funded systems. Personal budget is to take the public money that would be used by the municipality to pay for your home care and give it to the patient, give it to the client, essentially give it to them on their cell phone and say to them, you can decide who you want to hire. You can decide what mix of services you want, how much you want for personal care, how much you want, or whether you have family members who will do shopping for you and you don't need that service, so forth. You can also top it up. You can add your personal money in addition to the public money. And then you choose from a pre-selected group of providers. This is to make sure that you don't have providers who are not capable of providing the services that they're being contracted for. But then the individual client chooses the people they want in their house, basically. And these have become very popular. They're now 9% of the total long-term care budget in the Netherlands. And in fact, the government is a little upset because so many people want to use it and they see it as money they can't control. So that's within this structure of decentralization, that's a particular fiscal tool that has been created. All right, summarizing and pulling this all together, The new pattern is to both re-centralize and decentralize at the same time. The emphasis is on municipalities, municipal governments of various types and structures, becoming more responsible for dealing with the chronically ill elderly, and essentially becoming a support point, so that the first point of contact, the first point of seeking care for chronically ill elderly is not the more expensive allopathic healthcare system, is not even not just primary care, but is certainly not the emergency room and not the hospital. And on the financing side, in contrast to that decentralization, there is re-centralization, with national governments taking more and more control over steering the money and being very explicit about where it can be spent. So I hope that gives you some sense of the complexity, some sense of the ferment, some ideas that might potentially be transferable. I look forward to your questions and discussion. Thank you.
Thanks very much, Richard. Before I call on Greg, just we'll have some questions after Greg speaks for both of them, but I don't know if there are any burning questions. One thing I know we had in discussion earlier this morning in terms of physician accountability, Richard did note that most, particularly hospital-based physicians, are salaried employees of most hospitals across Europe.
Salaried and unionized.
Salaried and unionized, actually. So as far as the actual kind of payment, particular kind of system. But I don't know if there are any particular questions that might be kind of burning. Richard, if you want to just use the mic there.
A question particular in the Dutch system. So in ours, it sounds like a lot of, to use maybe a more pejorative term, of an offloading onto the family. In our system, we estimate we have about $4 billion of unpaid care as well. But we also, depending which measure you use, we find that 20 to 40% of our unpaid caregivers are in a stage of burnout. And so when they burn out, of course, you know what will happen. So our question is, are there supports that are put in place, or that can be put in place, or that the Dutch put in place to help the caregivers so that they don't burn out and they can maintain that level of care?
Very good question. I actually don't know if the Dutch have done it, but the Nordics have done it. Excuse me, the Swedes, the Finns, the Danes. They provide to members of the family or neighbors who are informal caregivers. At public expense, they provide respite care so that there is not burnout. They also provide telephone call-in lines for advice on how to deal with particular problems. They have tried to do some training on informal caregivers, although it's technically it's an issue when you have paid, unionized municipal home care workers, how you negotiate this. So in the Nordic country, they give pension points, this is a state pension, to informal caregivers who stay at home and take care of somebody in their house. But that's a pattern that the Nordic countries have put in place previously for childcare. So for them, it was a relatively easy thing to do. Those are all efforts, obviously, to try to extend the longevity of the informal caregiver, which is a fancy way of saying making sure they don't burn out. In terms of offloading, the argument that's made about offloading is typically made more with regard to the formal care system. And there are those who fear that this is just basically a way of government no longer assuming as much responsibility as it used to for what are seen by citizens as important services. I think this time around the Dutch may have minimized the ability of people to make that claim. But it remains to be seen. Again, that reform started in 2015. There was considerable turmoil. The most recent academic work does not evaluate these outcomes, so we have to see how the process works its way out. It may well differ in different municipalities. Many of you are aware that when you decentralize, The expectation is not that you're going to have equal services exactly the same to everybody. The whole point of decentralization is to fit to the local circumstances and local capacities. And inevitably, you get variation. This is where central decision makers get nervous about decentralization. They say, well, it's inequitable. It's not the same standard in different places. And that's often where there's a strong impulse to claw it back into centralization. So that's part of it, too.
Well, thanks, and I think I'll just move on to Greg now and then get you back up. Richard, certainly we deal with the issue in Alberta with a single health authority to be able to be responsive locally. In the back, the centralized, decentralized kind of pendulum which comes forward is certainly reticent or certainly present here in Alberta.